Good afternoon, everyone. How is everyone? Uh, Great. I hope you all have been enjoying the programming this afternoon. It's been really great to see you all in person and be doing this in person. So I'm stepping in as the moderator for this panel. So our board member, Robert, has the flu, and thankfully he didn't bring it here for all of us. And so we brought together this really awesome panel. At ITUP, the theme of our past two virtual conferences has centered around health equity, and something that we can't achieve health equity if we don't start thinking about how to be anti-racist and how to build a healthcare system that is anti-racist. And what that means to me, I think, is, and how we sort of wanted to frame this panel is, it's an action. It's what are we going to do, not what are we going to talk about, what's the theory behind it, but what are the actions to truly make a healthcare system that is for diverse communities across the state of California. And so with that, I think part of that also is explicitly naming that racism is a problem in our healthcare delivery system, that inequity stems from racism. And so I'm gonna, we brought together this great panel, and I'm going to actually have them all introduce themselves as they go through. So we're going to start off the panel with about 5 to 7 minutes of presentation from each of the speakers, and then we're going to have a little bit of a dialogue and open it up for you all to ask questions of our panelists. And so with that, I'm going to kick it off, and I'm actually going to start with Ronald. So I'm going to hand you. Thank you. Go ahead.
Good afternoon, everybody. Thank you very much for being here. My name is Ronald Coleman Baeza. I'm the Managing Director of Policy of the California Pan-Ethnic Health Network, CPEN. Creating an anti-racist healthcare system is something CPEN stays focused on daily when we're engaged in our statewide policy advocacy, and also as we're working with our community partners in many of our networks. CPEN brings together diverse racial and ethnic communities to work on policy changes that further health equity to reduce disparities and improve health outcomes, specifically in communities of color. We believe every human being deserves to live a healthy life to its fullest potential and thrive. And we also know that racism surely has played a role in impacting people's health care. Institutional and systemic racism certainly impacts housing, education, jobs, all of the things that we know are very connected to your health care. Not only has access been impacted, but racism also makes people sick. We know that health inequities stem from multiple issues affecting California residents, and so it's important to make sure that we build people power, pass changes at the statewide level, but also work in local communities to engage community members in order to push on policymakers at every level to make these changes. And so whether it's access to care, quality of care, social determinants of health, negative interactions with the healthcare system, and or just racism specifically, we know that health inequities are baked into the health of people of color. And so racism directly impacts both the physical health and the well-being of countless Californians. And we also know that racism is a public health crisis, even if the state of California refuses to declare it as such. So for us, we don't necessarily believe we can reach health equity until everyone has access to quality, affordable, culturally competent care, regardless of their race, their ethnicity, their age, their ability, their sex, their gender identity, their gender expression, sexual orientation, immigration status, socioeconomic status, and or geographic location. So how does this show up in CPEN's work? And so CPEN actually engages in 3 broad issue areas related to healthcare delivery. One being healthcare systems, another mental health and oral health, and also in public health arena. Essentially, we work to eliminate racism across these areas, whether it's working on the healthcare system specifically, whether it's trying to think of innovative approaches to addressing mental health or advancing health equity and oral health, and also as we think of what's needed particularly in the public health space. As it relates to health systems, specifically, one of the big issues that CPEN focuses on is addressing data. We definitely want to make sure that we have more access to better standardized data that we can use to really identify the health impacts that are facing communities and do what we can to address them. Data certainly remains to be a big focus. Another big focus is workforce as it relates to health systems. And so CHWs is a big issue as it relates to making sure that we have an anti-racist healthcare system. CPEN just launched a coalition to support DHCS's new Medi-Cal benefit to establish CHWs for Medi-Cal enrollees. Mental and oral health care. CPEN is doing a lot of work on this issue, particularly in mental health as it relates to outreach and education, making sure that community members understand what access they have to certain services in programs like Medi-Cal. We found that many communities of color do not access Medi-Cal services related to mental health in the same way that white community members do. And so it's important to make sure that we actually have strong outreach and education measures in place. Additionally, CPEN is doing a lot of work working with local organizations all over the state to really identify how we can move local communities as it relates to advancing mental health, whether it's related to county services or also making sure that we can provide streams of peer-based services to community members as well. On the oral health care front, certainly we're also noticing that outreach and education is critical to communities on that front as well. Many communities may not know what benefits they're actually eligible for. At times when the California budget has been in a difficult spot, sometimes benefits for dental care for adults disappear. And so we've just brought them back, I think, about 5 or 6 years ago. And so, there needs to be a big education effort to make sure people understand what's out there. Also, we need to also make sure that communities of color have strong access to oral health care. On the public health care front, we're also doing a lot of work to really make sure that racism is at the forefront of how we are thinking of what's needed on the ground for communities as it relates to making sure that we have a comprehensive healthcare system in place. And so that means we need to make sure that local communities are able to work with their governments and that governments are listening to communities and that there's actually interactions and conversations to moving forward to ensure that collaboration and coordination can happen between community members and public health jurisdictions. So I'll say a little bit more about some of the specific work CPEN is doing in some of these areas. And so racism as a public health crisis. A few years ago, after the murder of George Floyd, CPEN launched a campaign with Black Women for Wellness, Black Women's Health Project, California Latinas for Reproductive Justice, and Roots Community Clinic in order to push the state of California to make specific intentional investments as it relates to treating racism as a public health crisis. We wanted to see investments that were going to ensure that communities could advance towards racial equity. Part of this push was to try to get resources, specifically from ARPA. A lot of dollars came into California to push the state of California to make down payments, make an investment towards different innovative programs to advance racial equity. Now, there have been legalities that have gotten in the way of the governor actually declaring racism as a public health crisis. Certainly, our effort did not succeed, and then also Dr. Pan with SB 17 tried to get the governor to declare racism as a public health crisis, but unfortunately, it hasn't happened. Everybody in this room, I bet, understands that racism actually is a public health crisis, though, and so there is still much more work to do to push on the state to make the appropriate investments to ensure that communities of color can get the innovative programs it needs to ensure that there is a comprehensive public health care system in place that does adequately and appropriately meet their needs. The next issue that CPEN works on to foster an anti-racist healthcare system is the Health Equity and Racial Justice Fund. Certainly, we have proposed the Health Equity and Racial Justice Fund, which would be a proposal that would allow for community-based organizations, clinics, and tribes to get state funding to advance healthcare projects that focus on health equity that are related to social determinants of health and also racial justice innovations. In the first year that this proposal was pushed, the state legislature actually allocated about $100 million ongoing. In the second year, it was $75 million over 2 years. This year, we recognize that we're facing some pretty difficult budget hurdles, right? But we also know that there's a strong need on the ground for money to support tackling social determinants of health and also racial justice innovations. And so we're gonna do the work we need to do to make the policy changes to bring the governor and stakeholders on board, and also try to figure out if there is going to be some dollars available for us to squeeze out to ensure that we can get this funding in place. Another issue is improving the Racial Equity Commission. And so back in 2022, in September of that year, Governor Newsom put out an executive order to launch the Racial Equity Commission. This came out of the advancement of SB 17. Of course, the governor didn't want to create an Office of Racial Equity, but he did agree to create a Racial Equity Commission. The problem here is not that a Racial Equity Commission is created. All of us want to make sure that there is a body within state government that makes inroads towards tackling racism specifically within government. But at the end of the day, we need to make sure that it's intentional and specific about what it's doing. This agency, the Racial Equity Commission, will be directly connected to agencies like the California Health and Human Services Agency and other departments under that umbrella. And so it's going to be really important to make sure that there's intentionality in how this works. Right now, there's no definition for racial equity. And so, if there's no definition for racial equity within the Racial Equity Commission, I'm confused at what direction state government has as it relates to fixing the problem. And so, one of the things that I think CPEN wants to do with partners over the course of the next couple of months is really push on the state, push on legislators, push on the governor to actually have a meaningful proposal in place as it relates to the Racial Equity Commission and ensure that it actually has intentionality, defines racial equity, and also includes channels for community engagement, which have been missing thus far. Another issue is enhancing data to reduce disparities. And so I said a little bit about this, but I'll say a little bit more. You know, data isn't great. You know, we have a lot of it in some ways, but the data is not necessarily always usable because of different requirements on providers or health plans, depending on who's paying. You know, sometimes we don't necessarily get all of the same data fields from various entities. And so one thing that's going to be important is making sure that we can standardize data across entities. And so we're really excited about the Health Information Exchange potentially coming our way this year and moving towards implementation. We think that this is going to be a big change for consumers to really ensure that information gets to where it needs to go when people need the care they need to get. And so that will be one big issue to work on, but we, at the end of the day, need better standardized, more granular data. We need more demographic data collection. We need more SOGI data collection, sexual orientation and gender identity data collection. You know, there are so many gaps in place that we can't really figure out where all the problems are. And until we find the missing puzzle pieces, we're not going to be able to solve any of the problems. Lastly, I'll say engaging communities to reduce bias is going to be really important. And I may be out of time, so I'll speed up. I think on this piece, and I said a little bit about this, this has come up, I think, particularly in our public health work, but really shows up across mental health, oral health, and also health systems as well. Really making sure communities are part of the conversation, making sure impacted individuals are at the table. You know, we can't have conversations about changes to policy that are impacting people's lives without really understanding all the ins and outs of the problem from their perspective. And a lot of times we're sitting in our offices and we're thinking of really great ideas. We know a lot of facts about policy. We know a lot about different health proposals that have come together over the years, what's worked, what hasn't. But what often doesn't happen is engaging communities directly and talking to them about, what do you think the solution could be for your life? And so we think that is crucially important and a missing puzzle piece to the equation in order to ensure that we can truly understand what's needed on the ground for communities of color. And so, this shows up when we learn issues about people using certain medical devices that might not work on all community members. There might be a certain type of device that doesn't work on darker skinned, complected people. This shows up when it relates to how communities may need to organize around bias that shows up within the healthcare system and ways that they may be able to deal with the bias in the moment when it happens. This is also about making sure that we can have more community engagement processes when healthcare policies are advancing, really making sure that people are embedded into the conversation and that they are able to really share what they're thinking about various policy approaches before they're passed, before they start getting implemented, before they start impacting their lives. And so I'll stop there. Here's my information. Feel free to reach out if you have any questions about our work, but certainly I think that you definitely have a friend in CPEN if you're looking for an organization that is really laser focused on health equity, specifically with a racial justice, racial equity lens.
Thank you so much, Ronald, for not only talking about your state level advocacy effort, but also keying up our next speaker, Myra Alvarez, who does work with communities and will give us a little bit more about that community perspective. Take it away, Myra.
Great, thanks so much. Yes, you'll hear some similar themes between Ron and my presentation, and I'm sure our fellow panelists as well. Before I get started, I really want to thank the entire team at ITUP for the invitation to join you. I'm honored to be a part of this panel and this discussion and really bring the specific perspective of children's advocates, really recognizing that children are part of families and families are part of communities. So the work that we're doing to advance racial equity is really the responsibility of all of us. So I appreciate the opportunity to be here. Oh, just kidding. We have effects. Sorry, this is new. So for those of you that don't know the Children's Partnership, I hope you get to know us. We are a statewide advocacy organization focused on advancing child health equity. And we really pride ourselves in working closely with our partners at the local, state, and national level to advance a shared agenda around child health equity and seek to dismantle the systemic racism that's baked into many of the systems that are supposed to serve our children. So whether that's our education system, our social services system, our healthcare system, and more, really trying to identify how it is that these systems that have not been set up to support our communities of color, our marginalized communities, how can we dismantle that systemic racism together in order to advance the well-being of all of our kids? Just kidding. One thing that I want to note is that as we consider the healthcare system, my presentation, my few minutes with you today, will focus on some of the great examples that the state of California has begun to put forward in order to demonstrate the commitment that's needed to move in the direction of a more anti-racist healthcare system. And I'm going to raise three overarching themes that demonstrate this commitment to systemic change, again, to try to foster this anti-racist healthcare system. The first is considering families as experts. The second is community leadership and valuing it. And the third is strength and partnership. And you'll see some familiarity with what Ron said, right, as far as the themes that I'm identifying. So first, some context for you. This slide was borrowed from our esteemed colleague, Dr. Rhea Boyd, who used an image from the work of the incredible Dr. Wendy Ellis that really speaks to the community resilience framework the state of California over the last few years has done an incredible amount of work and awareness building around the impact of adverse childhood experiences on the well-being of Californians, from childhood into adulthood. What this slide really provides as context is that there's more to the story when it comes to the well-being of our children and families, and that we need to consider the conditions in which our children are raised, the community environment in which we are putting the responsibility on families to raise healthy kids with factors that are completely out of their control. So again, recognizing that the work is not just about fixing people or focusing on individuals, but it's about addressing what's in the environment that exacerbates the adversity that children and families are facing. And so as we consider the work ahead of us to really drive systemic change in our healthcare system, identifying how we can influence and impact these community conditions in which children are raised is an essential part of the work ahead. Okay, so theme one, really considering families as experts. Over the last few years, the team at the Children's Partnership, Kristen Golden Testa, Gabby Benitez, Gabriela Barbosa, and a number of other staff that have been engaged in our efforts to really listen to families on the ground. One of our projects has been the Equity Through Engagement project in partnership with California Children's Trust and the Georgetown Center on Poverty and Inequality that really spoke to families across the state to identify what are the challenges with their Medi-Cal plan. What are the challenges in accessing care? What type of information are they getting or not getting? Do they feel valued? Do they feel heard? And as you can imagine, a lot of what we heard was that they're not considered the experts in their children's care. Similarly, in a project that we did in partnership with the Lucille Packard Foundation for Children's Health and a number of family resource centers and family voices, was we listened to parents of color of children with special health care needs. When you think about a targeted universalism approach to our work, which is really centering on the most marginalized communities in order to impact changes that help everyone, when you consider a person of color, oftentimes an immigrant that doesn't speak English or has limited English proficiency, and their children that has special needs, that's as targeted universalistic as you can get, right? And the idea that is these communities that do not feel valued, heard, or even understood in the healthcare system that is supposed to support the well-being of their kids, really elevated for us the need to circle back with families, the need to meaningfully engage those experiences in order to improve the delivery of healthcare services. And you heard this in the Secretary's comments this morning and the first panel, really thinking about what does meaningful engagement of our communities actually look like. And I'm encouraged by the Department of Healthcare Services and other folks at agency that have put forward changes to things such as community advisory councils. But what more can we do to really hold ourselves accountable to that commitment to engaging people with lived experience and again, in their decision-making authority? Because as come up time and time again today, that power differential is really what is causing much of the disconnect between people with lived experience and the impact to make positive change. So the second theme that we've identified, in thinking about what do we need to move forward in an anti-racist system, really is around community leadership. And again, we've heard a lot today about these last 3 years of the pandemic and this ongoing multiple pandemics that families are facing. And when we consider the work that's been done these past 3 years, it's been a heroic effort by government agencies and our healthcare systems to really help us get through. But if you really think about it, it would not have been possible to overcome what we have overcome without the leadership of our community partners. The reality is that our systems, again, our health system, our early childhood system, education, judicial, they're not set up to support historically marginalized communities, families, and their children. So the second theme really does center on uplifting the knowledge, expertise, and leadership of community. And nowhere is this most obvious than in the moving forward of a community health workforce. The move to integrate community health workers in our Medi-Cal system is a tremendous opportunity to, again, make our healthcare system more equity-centered. And it's long overdue, because what we know is that community health workers and promotores, they've been in our community. Community-based doulas have served in our communities for far longer than the recent policy initiatives that we're all so excited to applaud and ensure that we're moving forward with implementation. But it's been done as a result of the system not meeting the needs of our communities. Communities themselves stepped up and implemented the solutions that we are now trying to integrate into the system that wasn't serving them in the first place. And you can see this time and time again. For many low-income families, when they can't afford a child care center, they have an aunt or an uncle step in and says, I'll take care of your kid. For people that are going hungry and don't know where to find food or don't have a job that helps them afford that, they have neighbors that step in. They have family members that will step in. If you think about someone who cannot navigate our healthcare system and has a lump in their breast, they often go to someone that they trust to help them navigate the behemoth of a system. That, in and of itself, is a promotora that was built from the ground up. And now we're seeing that out of necessity, we saw communities created these networks of care, these community health workers, again, in response to systems that were not set up to meet their needs. So as we're moving forward with these exciting initiatives that the Department of Healthcare Services and other agencies are putting forward, the onus should be on the system to welcome community health workers and find ways to integrate them seamlessly and ensure that we're not putting up additional barriers that block us from seeing the very benefit that we know exists for decades as a result of community leadership. And also to be aware of, again, those power dynamics and the administrative burdens that so often hinder equitable care delivery. Another exciting opportunity by HHS has been the Children and Youth Behavioral Health Initiative. Again, as we seek to rebuild systems to better serve children and families, we're trying to eliminate the harms that have been visited upon communities of color and instead prioritize solutions that challenge the status quo, that bring care, social services, legal support to families in the community, initiatives that refuse to allow healthcare to be transactional and recognize, again, that children are part of families, and finally, to validate this brilliance of community leadership. And I think that we can argue the Children and Youth Behavioral Health Initiative is an incredible opportunity to do just that. Again, holding ourselves to the systemic change necessary to make these changes sustainable is the next step in making sure these changes are for the long haul. And a few examples could be, one is dyadic care services. This is a wonky term, dyadic care, right? But if you really think about it, it's the idea that a child and their parent cannot be separated, especially those first few years of life. Folks know this. It was a long journey. I'm the mom to an 18-month-old. I've been to the doctor more times in these 18 months than in the last 10 years of my life, right? I would never expect my child to get dropped off without me, or I would never expect my well-being to be separated from hers. The idea that we are moving forward a dyadic care model is not only logical, right? I'm thinking about parents and their babies. It's a step in the direction of being anti-racist because it's refusing to allow healthcare to be transactional between one person, between a service, and then you're out the door. But really thinking about the family as a unit, something that cultures have done for hundreds of years. The idea that a family as a unit and their well-being is directly connected to the individuals that make up that family. Another example is youth peer-to-peer programs and peer-to-peer support more broadly. The state of California has moved forward SB 803 that looks at adult peer support in mental health and the importance of supporting peer leaders in the experience of mental health. Doing that same type of investment for young people is what we heard through our Hope Healing and Health Council. When we asked young people from across the country, what do you need to support your well-being? Of course, people want mental health services and they want more supports, but you know what came up time and time again? It was the idea that they wanted somebody to listen to that looks like them and that shares their experiences. So that same peer support model that we know works for adults also works for young people. And the opportunity to invest in those types of programs to determine how we can change our healthcare system to be more responsive to the needs of young people is a step in that direction of anti-racism. And then, of course, community-defined practices, something that CPEN has led on for many years with partners across the state. Again, recognizing the value and brilliance of community programs in responding to crises and providing supports and services that help prevent those crises of mental health. How do we integrate those practices at the county level and also statewide, again, in order to step outside the box of what traditional mental health care looks like? Right? One of our staff, Angela Vasquez, always says, therapy isn't always the only thing that's therapeutic. There are many things that are therapeutic, and really challenging ourselves to think outside of our box of traditional mental health care service delivery and how we pay for it is particularly important, again, to moving in that direction. And the last thing I will say is my third theme, which is strength and partnership. I wanted to close around where do we want to go when it comes to our commitment to equity. And our ability to really advance these meaningful systemic changes for children through our policymaking process really relies on our ability to break down silos, to redefine what a challenge is, and to align efforts. So much of the challenge in advancing more equitable outcomes is caught in the navigation of systems. I feel like I'm a broken record, but I constantly carry this quote by Audre Lorde, right? There is no such thing as a single issue struggle because we do not lead single issue lives. And that quote resonates with every single Californian, regardless of their income level, regardless of their background. They're navigating multiple challenges. But if you think about a low-income parent who has a child, who can't make rent, who's trying to put food on the table, who also needs a child care center, there are multiple challenges that they are navigating. How do we ensure that our systems are set up so that it's much less of a burden for that person to access the supports and services for which they have a right in order to raise their healthy, thriving child? How do we place the responsibility of the burden of navigating those systems, of paying for those services on our system rather than the individual themselves? It's what we saw made possible during the public health emergency, when we didn't make people jump through hoops to redetermine their eligibility year after year. We continuously covered families during the public health emergency because it was necessary. We were in a public health emergency. But you know what I think was made more clear is that it's possible. It's possible to keep people enrolled. And now, with the unwinding of that continuous coverage provision, we are at risk of millions of people of losing coverage, millions of people that need that coverage in order to stay healthy. And what the federal government predicts is that the overwhelming majority of folks that will drop off the rolls actually will remain eligible. So again, how do we think about moving forward in partnership and putting the responsibility on our systems to meet people where they are, to listen to families as experts, to value community leadership, and to work with partners across different sectors in order to advance our shared goals? So I'm excited to do that with you. Our entire team at the Children's Partnership stands ready and open to connect with folks, and we're excited about the conversation. Thank you.
Thank you, Myra. And also a good segue, we'll hear from part of our system next with Martha Santana Chin to talk about a health plan perspective.
All right, so I have to admit, very tough acts to follow. I love the passion in the room, and just one thing that I'll reflect on. I'm Martha Santana Chin. I work with HealthNet of California. I run our Medicare and Medi-Cal programs. We serve about 3 million members statewide, the majority of whom are in our Medi-Cal program, and they are the very individuals that we're speaking of today. But I'll just first reflect. It's an awesome time to be working at a health plan level, having grown with a family that had many of the same struggles that our members face today, and knowing that we have the potential to partner with organizations like this, and that we're doing it. One of the things that happened through the public health emergency is that it was a bit of a forcing mechanism to require us to think differently, remove barriers, and collaborate at levels that we've never collaborated before. And as a result of that, we planted a number of seeds that many of which had been planted many, many years ago, and some of which were new seeds that we planted. But now, between what has happened with the public health emergency, new levers that the Department of Healthcare Services and our governmental agencies have put in place, plans are now in a position to make an impact like we never have before. And so it's a good time to be in this field, working in this space, if you're really interested in making a difference, and very optimistic about the future. So for us, the first thing that's really critically important as a health plan is to recognize that we have an obligation to our members to understand what issues are affecting their day-to-day lives and what is getting in the way of helping them live healthy lives. It's not only about access, it's about quality, it's about connection, it's about engagement, and it's about busting barriers as much as we can to allow them to live healthy and fulfilling lives. And so recognizing that racism is endemic in our society and very prevalent in our healthcare system, and also the fact that this didn't happen overnight. It was decades and decades and generations of policy that led us to where we are today. So we're going to have to break those things down one thing at a time. But for us as a health plan is about optimizing everything that we have at our disposal, including the partnerships, including policy, to move things ahead and to address things head on and just make sure that we have a focus in what we do day in, day out, whether it's answering a phone call from an individual member struggling with an issue that is looking to get connected, or whether it's how we design our contracts with our providers to make sure that they have the ability to do the work that they need to do. We've got to look at it through that health equity lens. And part of that is also acknowledging that it's not just, minorities and peoples of color, but there are many individuals that have intersectional identities that have barrier upon barrier that they've got to work through. And so us owning that and supporting them in that process and empowering them to inform our own programming is part of how we think we're going to really make a difference. Now, as a health plan, one of the things that we are accountable for is driving improved health outcomes and advancing health equity. And so for us, it's critical that whatever data we have at our disposal, we make the best use of it. Over the years, we've invested quite a bit of money, time, energy, resources, hired people, looked at things in a variety of different ways. And we're using what I call traditional data, right? Claims data, encounter data, authorization data, pharmacy data. But over time, we've also added information that's flowing through the health information exchanges, are now connecting with the continuums of care, gathering housing-related risk data, incorporating what we're getting through risk assessments that we conduct for our members that include social drivers of health, or, things that they're identifying as barriers, and applying a race, ethnicity, and language, and in the near future, SOGI lens, to understand what are the disparities that are driving, that need to be addressed in various communities. And so all of that, in addition to really looking at member experience metrics through those same lenses, helps us understand where we're going wrong, where we need to focus, and where interventions may be necessary. And then also do the diagnostics to identify the root causes of what's driving the issues, whether it's the need to improve patient satisfaction, or the need to improve quality, or the need to improve access. All of those things, if we're not able to look at each and every one of those dimensions through those different lenses, we won't be able to effectively diagnose the problem and take action. As we move forward, one of the things that we're very much looking forward to is doing this in a very strategic and systematic way under a new construct, and I'll talk about that in a second. But the data that we have is very powerful. And if organized the right way and shared at the right level with our community-based organizations, our provider partners, and our members who sit on our community advisory committees, they will help fuel the change that we need to make, the interventions that we need to make. And so we believe that the data that the health plans have can be a very powerful tool if we're using it wisely and in a very targeted way. And so that's very much what we're focused on. As we think about how we work with our community, first, it's our members, right? We've got members that sit in community advisory committees up and down the state, and it's an art to actively engage members, to feel like they can contribute, to raise their voice, to be part of the solution. And so we are going as far as investing in our own training for our own team to make sure that not only from a technical perspective and an access perspective, our members have the ability to engage, but that we have the skill set to engage them effectively. And so that's part of the design of our programming. The work that we do is very much informed by the voices of our members. And one of the things that we're going to be rolling out later this year is what we're calling community impact councils. So earlier I talked about the data, overarching data, and it starts with identifying disparities, priorities, communities. That data and those insights are being given to our community advisory committees at a local level, and we are unleashing the power of that information and those insights so that those communities can help us address some of the health disparities that can't necessarily be handled alone in the doctor's office or at the plan level, but it really takes a community organizing effort. And so the idea being that it's only with partners like those that we have at the table and, you know, many of you out there in the audience today that we're really going to be able to make a difference. And the other thing that we recognize that there's many efforts in the communities that are already underway that if we just put a little more time, energy, and resource into, we'll be able to make the impact that they're looking to make. So we don't have to recreate the wheel, we don't have to reinvent anything, but community is critically important and those voices really matter. Supporting provider enablement is another very important part of the work that we do. By definition, we serve members in health professional shortage areas. So by definition, these providers are resource strapped. The communities they serve are resource strapped. And so as we're identifying an opportunity to improve quality and address a health disparity, part of what we do is target specific provider offices, clinics, locations, et cetera, and work with them to understand what are the issues that they're struggling with. And sometimes it's as simple as they don't have the resources to call members to bring them back to get their, you know, preventative care needs met. Sometimes it's a matter of location and transportation is an issue that we can help support and facilitate. And sometimes it's, you know, technical issues. They need a high-low exam table for you know, people living with disabilities, or perhaps they need the ability to connect their data systems because they're doing the work, they're just not getting the credit. So provider support and enablement is another key aspect of the work that we do. Community-specific programs and partnerships is also something that we've embraced for many years, and we're continuing to build on it. A couple of examples that I'd like to share is as the new benefits are rolling out, so Myra talked about community health workers, the doulas, dyadic services. There are organizations in the community, as was mentioned earlier, that have been doing this for years. We don't have to reinvent the wheel. And so we've actively sought their guidance on everything from how to design a contract to make it simple for community health workers and organizations to contract with us, to giving them the technical assistance that they need to engage and transact with the health plans, to training, pipelines, workforce development, and getting people placed into the networks that are contracting with the plans to do the work long term. The other example is work that we're doing with schools and organizations that are school affiliated. We recently expanded an innovation that we launched through the pandemic where we're bringing telehealth services to the side of the school nurse. And that telehealth service is connected with behavioral health professionals that are there to help serve students, the nurse, and then after they leave school, their families. And these behavioral health professionals are then able to connect them with their, you know, regular treatment sites if they have that connection, or get them connected with new treatment sites if they're not connected already. But all of that wouldn't be possible if we weren't able to work in the community with the schools, with these organizations, and really, you know, making sure that we're championing some of these innovations. And then lastly, it's equity-focused value-based payment. So HealthNet has had a long history of value-based payment for providers. We incent good quality work and effectively managing care. What we're doing now is also applying that health equity lens, understanding where these underserved communities are in most need, looking at quality, and then targeting investments with the providers that are serving those communities so that they could do what they need to do to improve access and get their, you know, advance their work. And then lastly, I wanted to share this quote with you from the Institute of Healthcare Improvement. And one of the things that HealthNet recognizes is that we have to approach all of this with humility. We have the benefit of working in a state that recognizes the importance of how to get much needed care to the members that we serve. We also recognize that education is really critical. And so as an organization, we have for some time, a significant number of years, been really focused on cultural competency. We have diversity, equity, and inclusion strategies. It's embedded in everybody's goals. We have employee inclusion groups that are focused on a variety of different affinity groups. And the idea being that we have to learn more and more every day. cultural competence is not a training that you take and then all of a sudden you recognize all the ills of the past and you know exactly how to solve for it. It's a learning journey. It's a learning journey for all of us, and every day we learn something new, but we're making it a priority to make sure that we're making the space for our people to do that, and leveraging data to find problems and identify solutions. But it's a journey and one that we're very excited about taking and partnering with the department and others to really make a difference. And you know, with that, I'll turn it over to Dr. Uberia.
Thank you, Martha.
I want to make sure that we have enough time for questions from the audience. I'll try to breeze through most of this, but happy to go deeper during the Q&A if helpful. So I am Paliv Babaria. I'm the Chief Quality and Medical Officer and Deputy Director for Quality and Population Health Management here at the state of California for the Department of Healthcare Services, which obviously runs our Medi-Cal program. Not when I'm in my day job, but aside from that, I'm also a primary care physician, and I have always practiced in our safety nets at FQHCs and public hospitals, including up to present day. And we'll lift up, if you don't take away anything else from the talk, that there is no pathway to health equity and dismantling racism in our healthcare system that is done without partnering with our communities and with our patients and our Medi-Cal members to redesign the entire system from the ground up. So if you're not doing that, then you're definitely doing it wrong. And I will also say, you know, my biggest education has been from my patients. They have probably taught me far more than my decades upon decades of formal education over the years. So there's a lot happening in CalAIM. I'm sure you guys are all tracking it, but we don't have 5 hours to sit here and digest all of that. So I will do a double click really just on the power of data and the power of putting our members back in the center of our design processes and what we're doing around that. So, you know, I don't need to tell you this, right? It's like in the data world, my oral health care and my mental health needs and my physical health are like in totally different siloed systems that never talk to each other, and yet here I am as like a single unified human being. And that's a major problem when we talk about whole person care. So as you all know, the whole point of CalAIM is how do we really break down those silos and take care of the entire being, and not just their healthcare needs that manifest after 20 years of crazy toxic stress from their adverse childhood experiences and their homelessness, right? But their upstream social drivers of health in addition to all of their physical, behavioral health, and other needs that they have. And so that is, you know, what the whole point of CalAIM is, and I'm sure you all know this already, but, you know, if you needed a reminder of why, you know, a manifestation of structural racism, this is it, right? This is who Medi-Cal serves, and this is not proportionate to who has commercial insurance in our country and who's served by other types of insurers. But it's also really critical to remember that if we really want to get to health equity and dismantling racism, Medi-Cal is a key driver and part of that solution. And if we can fix Medi-Cal, and if we can really improve and address all of those challenges that my peers up here have been talking about, we will definitely be in a much better place than where we are today. And so this is the question that, you know, me and my team at the state have been really grappling with. So how do we put patients back into the driver's seat around their healthcare information? For those of you who haven't read all 236 pages of our comprehensive quality strategy published this year, goal number 1 is really engaging members and empowering our members to be owners of their own care. And that is a goal that we are infusing through every single part of the various programs that we're running at the department right now. And so we really have this vision through our population health management program that went live in January, which is really exciting, and our population health management service, which is our multifaceted tech platform that we are designing right now, that we want seamless integration of data, right? And not just all those healthcare data pieces that we talked about, but everything else that we know affects people's lives, the communities they live in, what their neighborhood conditions are, what's happening in school, you know, which is where most of the children in our state spend the bulk of their time, not in their providers' offices, what is happening in social services, and what's happening in healthcare. And in current state, you know, all of us are sort of trying to do the best for the populations we serve, but we're not coordinated, we're not talking, and we are not exchanging data in a meaningful way. And then the burden of navigating all those sometimes duplicative, overlapping structures falls on the backs of patients and their families. And that is exactly the system we need to change so that that burden isn't borne by people suffering health disparities. And so our PHM service is really trying to leverage the power of the state, right? Sometimes the power of the state can be good, to really bring all these data pieces together and make them available to everyone who is caring for Medi-Cal members to provide comprehensive whole person care. And so, we envision the service being used by a lot of different entities so that if we have information about a Medi-Cal member, a mom who's newly pregnant and eligible for WIC, but she doesn't know that, doesn't know how to get to the WIC office and get signed up, that information is, not, oh, here's a paper, go call this, county social services agency, but automatically transmitted from her managed care plan or healthcare provider to the WIC office who can do outreach and say, hey, you're eligible for this benefit. Is this something you and your family are interested in? Let's get you signed up. There's a few other pieces we're really thinking through, around membership, ownership, and equity is really how do we, one, co-design the system with our members? So they are going to be part of the design process from day one so that the system and the service and the member-facing portal works for them. But how do we give members easy access to their data, right? Like we all, at the end of the day, own our own healthcare data, and I don't know if you've ever tried getting your medical records before, but it is not an enjoyable or really understandable task. How do we empower members to sort of use the platform to edit their information? So who has tried to ever outreach to someone using Medi-Cal contact information that we give you? It is not always accurate, as Martha can tell you after this meeting, and that is because the current process by which a Medi-Cal member updates their address so that when the redetermination notices come, they don't lose their Medi-Cal is really burdensome, again, on our members. So how do we leverage technology and the 21st century and apps on people's phones to really break down those barriers and make it member-centered, where we are making the systems work for the members and not the members work for the system? How do we enable members to own their data and then decide how that information is shared, with various entities and really protect their privacy? And then, why are we doing all this, right? It's not just to be nerdy about data exchange all day, although if you haven't seen the Cal HHS data exchange table out front, it is one of the more exciting initiatives happening right now and so critical. But it's because we have significant health disparities, right? If you live currently in the state of California and are covered by Medi-Cal and you are a child who is Black or Native American, you are less likely to get the care you need. You are less likely to get the immunizations. You are less likely to get the well-child visits, and that is just unacceptable, and we need a multi-pronged strategy to close all of these gaps. And that is, it takes a village. It is using community health workers. It is leveraging all the relationships that we've forged. And by 2024, 99% of all Medi-Cal members will be enrolled in a Medi-Cal managed care plan. And so it is also partnering with our managed care plans and bringing all of us who are really working to fix these problems together and breaking down our silos. I will also put in a plug. My team has a lot of vacancies and positions we're recruiting for, so I post all of them on my LinkedIn page. If you want to be a part of this really exciting journey, come apply for one of our positions.
Thank you, Paula, for giving us that very quick presentation so that we have time for questions. I'm going to use my moderator prerogative and open it up to you all for questions in the last few minutes that we have. Any questions for our panelists? No?
Hi, my name is Adriana Ramos Yamamoto from the California Budget and Policy Center. Thank you all so much for this really informative panel. I have a question for Ronald on declaring racism as a public health crisis, and just want to express appreciation for CPEN and all the other great community-based organizations who are just continuing to push for this. And I was really pleased to see it on the very top of the list of priorities that you included in your presentation. And so with this excitement for that, could you share a little bit about what are the specific efforts that CPEN and partners are going to be doing this year to keep that on the top of the priority list?
Yeah, and so I think, the main effort to advance racism as a public health crisis, both CPEN's effort and then also SB 17, were not successful efforts. I think that the governor feels that there are legal hurdles to actually doing the right thing to declare racism a public health crisis and actually putting resources specifically to address certain race-based issues. And so until we can get to a place to where the state does change their thinking on that, I think we likely won't see a declaration. With that said, I think in lieu of doing a declaration and also doing the Office of Racial Equity, I think the state decided to go the direction of having executive order on the Racial Equity Commission. It does not do what we would have seen in the Office of Racial Equity, specifically SB 17. But I think I say those pieces because I think where the work now is really focused on improving the Racial Equity Commission, again, to make sure that it is intentional about racial equity, very specific about what it should be addressing, providing more meaningful specificity, particularly to departments and agencies about what that means. I think it's great that an executive order comes out, but without the intention, without actually working with community to really understand what they may need from state government as it relates to racial government, we think that there are massive failures here. And so I think on the Racial Equity Commission issue, continuing to make sure there is a definition in place, also making sure that there is adequate community engagement is going to be extremely crucial moving forward. Then also making sure that there's a structure in place that creates a meaningful medium for work to happen that can actually be implemented in the future. I think many of us know how to solve problems that are caused by racism, but yet the governor has vetoed and or opposed many of those initiatives. And so, again, great that we have a commission, but I think we know many things that state departments and agencies can do to get their act together as it relates to this issue specifically. The last thing I'll say quickly is to focus on the Health Equity and Racial Justice Fund. I think that will be a big proposal this year that will continue to advance. And yes, we recognize that there is no money, but certainly the Transgender Equity Wellness Fund was signed into law and created as a program even when there was no money, and we were able to come back in a year or two when funding was in place and make sure that there was funding. For whatever reason, despite the fact that there are 200 organizations supporting this proposal, it has had strong legislative support for the last 2 years, the governor has refused to support efforts to deliver resources to community-based organizations, clinics, and tribes to actually continue to focus on health equity and racial justice projects. These are entities that are doing this work already. They're trusted by foundations and philanthropic bodies to do this work, and it's not enough. The state needs to step up, given that it itself has been complicit in racism on communities of color. And we haven't seen the state do anything to correct those past actions or do anything to make specific investments to change the course of where we've been in the past. And so I think, sorry, I'm saying a lot, and other people might have questions. I think at the end of the day, there are a lot of things that Governor Newsom has done to further health equity. That is undeniable. Now, as it relates to racism and racial equity, I'm waiting.
What a great way to end that panel. So if there are any other, we have time for one last question.
I was advised not to do it, but I will do it anyways. Great panel, admirers of all of you. It seems to me that one of the elements of structural racism that's staring us in the face is the fact that we pay providers less to serve our Medi-Cal population than we do to serve our Medicare population, or most of us in the room. And I'm curious, I think particularly for DHCS as a payer and Health Net as a payer, what your views are on that, and whether what you're doing to, I know that CMS just ordered California to pay a higher percent of Medicare, but it's, there's still a gap. So I'm curious how you think about that issue and your efforts to address structural racism.
Do you want me to take that first? I think there's a lot that has been written about the origin of Medicaid versus Medicare. If you haven't heard it, the 1619 Project's episode Bad Blood is probably one of the best concise summaries of that I've listened to in the last few years. And so it is a part of our country's legacy of structural racism and who is covered by Medicaid versus Medicare. I do think there's progress being made, and so the recent STCs as a part of our Justice Involved initiative did include certain rate adjustments for providers, and I know the department is looking at other options moving forward within that space as well, but it is a critical issue that I know a lot of people are looking at.
Yeah, and I've been working for a health plan for about 10 years. For close to 20, I worked on the provider side. I've always worked with Medi-Cal, every provider working in a provider office, federally qualified healthcare centers, systems, safety net hospitals, et cetera. And there is no question that reimbursement is an issue. We know that 65, 67-ish% of all available providers choose to serve Medi-Cal. And so even when we know there are health professional shortage areas, we know that that's further exacerbated in the Medi-Cal system because providers can't afford to practice. And so it's a real issue. From a payer's perspective, over time, there have been a few things that we've done to try and address that. Payment in each community does vary by specialty type. And so some of the high demand and low supply specialists, as an example, actually don't get paid only Medi-Cal rates. They get paid something above that because we have to do that to bring any level of access to the people that we serve. That being said, it's not enough. And one of the things that we worry about is when economic times turn for the worse, there is more tension in the system, right? And so historically, the state has had to make very hard decisions about whether to cover populations, cut benefits, pay less. And so, ahead of us there's difficult times coming, right? And so I don't know that there is an easy answer for the physician payment issue. It's one that's recognized and one that we'll champion as much as we can. But there's definitely an issue there that we're going to have to solve for if we're going to really address health equity.
Thank you. Thank you to our wonderful panelists, and thank you for your questions. Any thoughts?